Hello everyone, and welcome to today's webcast, Research Ethics and Informed Consent in Critical Care Research. Today's webcast is brought to you by Discovery, the Critical Care Research Network at SCCM. My name is Mohammed Effendi. I'm Clinical Assistant Professor at Ernest Mario School of Pharmacy, Rutgers, and Neurocritical Care Pharmacy Specialist at Capital Health Regional Medical Center in Trenton, New Jersey. I will be moderating today's webcast. I have no disclosures. This webcast is being recorded. The recording will be available to view on the SCCM YouTube channel within 5 business days. There is no CME associated with this educational program. However, there will be an evaluation sent at the conclusion of the program. The link to that evaluation is also listed in the chat box for your convenience. You only need to complete it once at the end of this webcast. Your opinions and feedback are important to us as we plan and develop future educational offerings. Please take 5 to 10 minutes to complete the evaluation. Thank you for all that are joining us. A few housekeeping items before we get started. There will be a Q&A session at the conclusion of the presentation. To submit questions throughout the presentation, type into the question box located on your control panel. You'll also have the opportunity to participate in several interactive polls. When you see a poll pop into your screen, simply click the bubble next to your choice. We would like to thank the Clinical Pharmacy and Pharmacology section for their work in coordinating the research webinar series. Our presenter today is Dr. Michelle Gong. Dr. Gong is the Interim Chief of Critical Care Medicine, Associate Chief of Academic Affairs, and Director of Critical Care Research in the Division of Critical Care Medicine at Montefiore Medical Center, and Professor in Medicine and in Epidemiology and Population Health at Albert Einstein College of Medicine in the Bronx, New York. Dr. Gong is a well-respected clinical researcher and trialist in acute injury and critical illness. Continuously funded by the NIH for over 15 years of her work, her current research ranges from ARDS to prevention of delirium, treatment of severe influenza, big data and predictive analytics in high-risk prediction, and effective clinical decision support systems. Her research has been published in the New England Journal of Medicine and JAMA, and she is currently the principal investigator for the AHRQ demonstration project on clinical decision-making in ARDS, and co-principal investigator for the Montefiore Sinai Clinical Center for the NHLBI pedal network focused on the prevention and early treatment of ARDS. Thank you so much for joining us today, Dr. Gong. Please take it away.
Thank you so much for the invitation. And thank you everyone actually for calling in and spending this time with us on this afternoon. So this is the outline for what we'll talk about today, but I thought actually we first should start with talking about what clinical trials is. And partly because actually a lot of the research ethics comes from actually whether or not we define your particular clinical research as a clinical trial. So first, let's start with a question, okay? Which of the following constitute a clinical trial under the National Institute of Health definition? Is it an observational study of patients from last year with influenza, a prospective before and after study of some kind of a QI initiative, a retrospective chart review of influenza patients on ECMO, a prospective study of patients on vasopressin for shock and SIADH, or an analysis of blood samples that was obtained from a prior clinical trial? Now let's return back to our slides. Oops. Okay. So we'll talk more about what the answer is for that particular question, but let's start by actually asking what is a clinical trial. So recently, the NIH has broadened its definition of what a clinical trial is and defined it as a research study in which one or more human subjects are prospectively assigned to, it could be one intervention or it could be more than one intervention. And the intervention doesn't have to be a drug or a device. It could be any kind of thing. It could be a quality improvement project. It could be a behavioral. It could be a education. But the goal, however, has to be to evaluate the effects of that intervention on a health-related biomedical or behavioral outcomes, whether it be a clinical outcome or it could be actually likelihood of people doing a certain thing, like performing a particular function or adhering to certain guidelines or whatnot. So under this broadened definition of a clinical trial, many things actually that have to do with human subjects now fall under the clinical trials realm, including mechanistic studies, studies that are exploratory development or pilot to determine actually whether something could be done as a trial. Other interventions that are not necessarily drugs, or actually behavioral, which includes actually a fair amount of QI initiative where you're trying to influence better adherence to a medication or better adherence to a particular guidelines or evidence-based practice. So clinical trials now include your traditional randomized controlled trial, but it also includes non-randomized controlled trials, all phase 1, 2, and 3 trials, all open-label drug safety phase 4 studies, and clusters trials in which an entire hospital or a particular unit, like an ICU, receives a particular intervention. And even actually before and after studies that were conducted prospectively, where you actually start enrolling the patients and then somewhere down the line, you do an intervention like a clinical program, and then you follow, and then you look at the patients afterwards, that now all could be defined as clinical trials. And that does include quality improvement studies in which subjects are prospectively enrolled, as well as any prospective studies looking at clinician or patient behavior with or without some kind of an education or training. What clinical trials do not include? Medical chart review studies. Most retrospective studies, even if there was some kind of a clinical or behavioral intervention, like you want to actually look at what has happened since a particular program was initiated like 6 months ago, for example. And studies in which you're using samples of data from patients that were enrolled in another clinical trial somewhere in the past. Just looking at those samples or just looking at that data doesn't in and of itself constitute a clinical trial. So with regards to our question, which of the following constitute a clinical trial under the NIH definition, it actually is number 2. Even prospective before and after trials of initiatives such as a QI initiative could be considered under the NIH definition as a clinical trial now. Now, why is it so important to know whether it's a clinical trial or not? Because actually some of the requirements in which you need to get IRB approval, consent, really falls under whether or not this is a clinical trial or not. And that leads to this question of centralized IRBs. So, question 2. Which of the following is false about the centralized IRB process? Is it a local IRB still has to review its trials approved by the CIRB? The central IRB performs annual reviews and amendments. Local IRBs can still reject studies approved by the centralized IRB. Same consent form is used by all participating trial sites, or is it local IRBs can consider local context and environment? Let me give it a little time. Okay. So there's good spread on the response, and that's good because that usually means that I'm talking about something that may not necessarily be familiar to everyone, which gives me an excuse to be here. So if we can go back to my slides, terrific. So what does it mean local versus centralized IRB? The first thing to figure out to decide whether or not you need a local IRB or a centralized IRB is to figure out whether or not, one, your study is a clinical trial or not. If it's not a clinical trial, then it's your local IRB for the most part, okay? If it is a clinical trial, then you have to say, is this a single center or a multi-center? If it's a single center, then it's your local IRB. But if it's multi-center, it depends on the funding. So the next question is, will the multi-center trial be funded? If it is not going to be a funded study, then it really just depends on what your local IRBs want to do. They could decide to consider a clinical trial. They could decide it's not. They could decide actually let's just do local IRBs at every site. But some local IRBs are deferring to NIH rules. So it really depends on your local IRB and you need to talk to them. If the multi-center study is going to be funded, then it depends on whether it's NIH or non-NIH. If it's a non-NIH or a foundation support study, then again, local IRB rules apply to whether or not they consider a clinical trial or they want to use the NIH definitions. And then they'll tell you whether you should go by the local IRB or some other mechanisms. And again, local IRBs are increasingly deferring to NIH rules. If, however, this is a multi-center study that is funded by the NIH. So for example, if you actually are invited to be one of the sites on a grant for a trial through the NIH, that's when actually the rules are very clear. And all of these studies and all approval needs to go through a centralized IRB unless the entire study was previously exempt by the NIH itself. This is no longer a local IRB decision. As of actually January 2017, the NHLBI and then subsequently actually all of NIH no longer accepts R mechanisms for clinical trials that are multi-center. Instead, actually, they have created two mechanisms. So if it's a single site, they use an R33 mechanism. And multi-center clinical trials uses a new mechanism that's a U grant is basically what it's called. Now, why is this important? Well, it's important because actually under this new mechanism, it requires a separate application for the Clinical Coordinating Center, or CCC, and a separate application for a Data Coordinating Center, DCC. In the past, you didn't have to do that. But one of the consequences of requiring these separate applications is that they require now a centralized IRB as part of the Clinical Coordinating Center. So as of January 2020, all clinical trials that are funded by the NIH will require a centralized IRB. And it was instituted to basically kind of help with multi-center clinical trials. Shortens the IRB review because it doesn't have to go through all 30 sites or however number of sites are involved in the clinical trial. It makes the review process more consistent. You don't have 30 different responses with asking for 30 different things. And because you make it more consistent, you can protect the scientific integrity of the trial. Because you can't have 3 sites deciding they want to change one exclusion criteria and another 4 sites says, no, I want to change the inclusion criteria. That can actually affect the science of the trial. And also, it's to decrease the administrative burden because the IRB process takes work, okay? But it doesn't necessarily mean that the central IRB does everything. It doesn't. What it is central IRB serves as kind of the hub, and then each site still relies on their local IRB. But each of these sites have their local IRB signs a contract with the centralized IRB. That's called a Reliance agreement. And the contract basically dictates how the local IRBs would defer to the central IRB in what and how, and what things may be specific to that particular site that the local IRB will require. The centralized IRB will review the protocol of the trial protocol and issues a template for a consent form. But then actually all this gets kicked back to the local IRBs. Now, a little bit here about the Reliance agreement. What I mentioned before is the Reliance agreement is really the first step to interacting with a centralized IRB. And it is basically a contract between the IRB at your institution with the central IRB. Now, this usually revolves the lawyers at your IRB kind of negotiating with the lawyer at the centralized IRB. But actually, because the NIH recognized that we need to actually have a better system that allows for more of these clinical trials, there is an initiative that was advanced actually by the National Center for Advancing Translational Science, where they created an electronic system that they called a smart IRB. And basically, it's a national contract, a national IRB Reliance contract. And any institution that has a functioning licensed IRB, so IRB that actually has an FWA or Federal Wide Assurance, and almost all of your clinical centers, hospitals will have a FWA issued IRB. And if you do, then your institution can basically just sign on as a participant in the Smart IRB process. And what that means is that you can use this kind of a generalized IRB, and it makes it much easier without having to go through all that negotiations between lawyers. So again, it's this process by if your institution signs on to the Smart IRB, then whenever there's a trial that requires a centralized IRB, they can just use that smart process instead of negotiating a new Reliance agreement with every single trial. Now, each of the local IRBs can put an addendum to the Reliance agreement to allow for things that they want to specify as special to your particular site, okay? And currently, actually, there are over 388 institutions that have signed on to the Smart IRB. And if you're from a site that actually has a CTSA, in all likelihood, you have your institution has signed on to the Smart IRB, which will make it easier for you then to work with centralized IRBs. Now, if this institution does not participate in a Smart IRB, and you want to participate in a multi-center trial that requires a centralized IRB, then you need to contact your local IRB and the centralized IRB, and you need them to start working together to negotiate their own Reliance agreement. Unfortunately, if your IRB is not willing to do that and not willing to negotiate a Reliance agreement, in all likelihood, you will not be able to participate in multi-center clinical trials. Now, having said that, most institutions are not stupid, and they know actually that they have to do this or they will be phased out of all fundings in the future. So there are very less and less institutions that will say now, oh, I don't want to participate in a centralized IRB. Okay. So it's important to remember that a centralized IRB, single center IRB, is not the same as a one institutional review. Okay. The centralized IRB do the IRB review and actually performs all the annual reviews, amendments, and the protocol deviations. But all these other aspects of what the IRB does still falls to your local IRB. So what are the responsibilities then of the local IRBs? The local IRB still has to ensure that all of your study personnel at your site has the necessary education, training, and qualification to be able to do the research. The local IRB still has to ensure that all of the research personnel in the trial complies with the compliance that's required at your local institution as well as within your state. In addition, the your institutional IRB still needs to review the study, even after the central IRB has reviewed it and approved it. But there, the focus of the review is much more narrow. They're supposed to actually look at the protocol and just ensure that all applicable local laws and rules are followed for that particular protocol. So an example of that may be, for example, this may be a clinical trial that just looks at tuberculosis, for example. But if one of the sites actually is a hospital that treats a high number of inmates and prisoners, whereas the other 30 sites, they treat general patients, then actually that particular IRB of that hospital that treats a lot of prisoners or inmates may have to actually do a additional review of the protocol that was approved by the centralized IRB to make sure that it is appropriate for prisoners. Okay, so that's part of actually the local context review. The local IRBs has to communicate to the centralized IRB any local laws, any ancillary reviews, any site-specific things for both the protocol as well as the consent form. The centralized IRB may generate the template for the consent forms, but the local IRB still has to add to it the local context and the local languages that are compliant with their state laws or whatever other institutional requirements they have. So everybody's consent form and all the sites do differ. The skeleton may be the same because it was issued by the centralized IRB, but the other languages in it may all differ by site depending on what each site wants. So this is basically actually a restatement of what I've said before, saying that actually each of the local IRBs still has to communicate to the central IRB any applicable state or local laws, regulations, institutional policy, standards, or other factors that are relevant to the research, okay? That means after they negotiate and sign a Reliance agreement, they still have to give the local context to the centralized IRB because the local context is best known by a local institution. And the local IRB has to provide language in the consent form that may be needed or specific to that institution. And then what will happen is it sends it back to the centralized IRB, and then the centralized IRB will issue consent form that's specific to your institution back to you to use for your research. So what the overall process looks like is that the trial may have an initial submission of the trial protocol, consent form, and other study document to the centralized IRB. The centralized IRB will review it, ask for any kind of amendments that they want to, and then ultimately approve the protocol and the template consent, which then gets sent to the local IRB. Then the local IRB basically reviews the protocol for any site-specific concerns and locally required languages for both the consent form as well as the protocol. It's not supposed to be for the whole protocol. It is supposed to be specific to the local context, but the local IRB can have the right to reject the protocol for that institution, okay? And then even after the centralized IRB, the local IRB still has to sign off and say, okay. For most part, this doesn't require a full review. Like all the centralized IRB that I have used, basically once the centralized IRB is okay, they have negotiated the local language for the consent form, then the local IRB would just say, approved, 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 okay? And then afterwards, the centralized IRB will do all of the annual reviews, protocol amendments, protocol deviations. The local IRB might sign off on an annual review, but any kind of addition of sites is done by the centralized IRB. So with regards to our question about which of the following is false about centralized IRB, it is actually answer 4. The same consent form used by all participating trial sites. It's not. They all may have a start off with the same template, but then each institution adds their own language to make it applicable to their local laws, rules, and context for that institution. So moving on, after the IRB review, you also, as part of the IRB review, and then as part of doing the trial, you have to obtain informed consent, which can be particularly challenging for critically ill and acutely injured patients. So let's start with a question. Which of the following is true about informed consent in clinical trials of critically ill patients? That critically ill patients are considered vulnerable population. Appropriate surrogate for research consent can vary by the site. A waiver informed consent does not apply for a moderate risk study, and an exception to informed consent can indeed apply for moderate risk studies, or all of the above. So good. I'm glad to see actually a little bit of a spread there. Let's go back to my slides. So there are different types of consent in clinical trials. The individual informed consent, where you actually get consent from the patient, is the most commonly used in randomized controlled trial, okay? And the common rule, which dictates actually how research is done in the United States, it actually dictates and requires that there is a signed informed consent before you can initiate any study procedure. Some of you may have read about trials in critically ill patients where because the patient is critically ill and because, it is on an acute condition like sepsis, shock, or respiratory failure, they would actually start the procedures of the study and then delay later on and get a consent afterwards. That kind of delay consent is not actually allowed within the United States. So those are actually studies that you'll see doing this are coming from Europe and other places. And even in Europe, they're starting to crack down on that. Critically ill patients in general are considered a vulnerable patient population by the common rule. So what does that mean? Vulnerable population can be defined as any subjects that has diminished autonomy. And ICU patients have a diminished autonomy to consent, between actually the fact that sometimes they're sedated, but also actually because they often have altered mental status, delirium, or in a coma, they may not have the ability to consent for research. Doesn't mean that every patient in the ICU cannot consent, but many of those patients may not. Even those patients who are not in a coma, it's not always clear that they have the full capacity to consent freely. There's also potential compromise in their ability to volunteer freely. For example, patients with emergency situations, patients with incurable or fatal diseases, or like marginalized social group, and the prisoners is one example of that, also can be considered as vulnerable and compromised. So I remember actually there was some of these studies that enroll like 10,000 patients for studying a cardiac stent when somebody patient comes in with an acute MI, and they will consent them before they get rolled into the cath lab for a particular type of stent to see if it's beneficial. They get the consent mostly from the patient, but one would actually criticize. It's like, well, if you're having crushing chest pain and you're having an MI, how able are you really at that point to consent to a study? So because actually critically ill patients and acutely injured patients are considered a vulnerable population, the common rule requires that they have an additional protection. And the most common protection afforded to critically ill patients is the requirement for consent from the patient's legally authorized representative. Now, what is that? This is also dictated by the common rule. So no investigators may involve a human being as a subject in research unless the investigator has obtained the legally effective informed consent of the subject or the subject's legally authorized representative. Now, what's a legally authorized representative? They define it as an individual or judicial or other body authorized under applicable law to consent on behalf of a prospective subject to the subject's participation in procedures involved in the research. That is about as clear as mud, okay, in many ways, especially because few states have laws that relate to surrogate research decision-making. Those are the 4 that you see. There is an additional at least 45 states that have laws on surrogate decision-making for medical treatment. So for the most part, most of these states then have basically extended their practice and research from these laws on surrogate decision-making for medical treatment. In general, if you are new to this type of research, I would suggest that you have a discussion with your local IRB to, one, make sure that they kind of have an understanding about what surrogate consent is, okay, and that it is allowed under the common rule. But also actually to have an understanding of who is allowed to serve as a surrogate. Most places will agree, if you have a healthcare proxy, that works, but many patients don't have a healthcare proxy. So is the spouse or is it your children? What about grandchildren? What about nieces or nephews? In general, most institutions will have some kind of a procedure, a hierarchy, which if they have like a state law that gives you some guidance on that, they will have adopted it from the state law. Or sometimes the IRB has basically created that for you so that you use that as the context by which you're going to be doing surrogate consent. But in institutions that are unfamiliar with this type of research, you may actually need to talk with them to educate them a little bit about this. Other vulnerable populations, prisoners, okay? In that particular case, there are additional safeguards. You can't do any kind of study that's more than minimal risk. It has to be on condition that's specific to the prisoners. It must be to ultimately improve the health or well-being. And one member of the IRB has to be a prisoner or a prison representative in order to do research that involves prisoners. And for that reason, you'll see that prisoners are often excluded from most clinical research. Children is another one that's considered vulnerable. So for those of you who work in pediatrics, allowable research includes research as minimal risk, minor increase over minimal risk with a potential direct benefit to the subject, or a minor increase over minimal risk even without direct benefit if the risk is commensurate with the risk involved in the child's condition or is likely to yield vital information about the child's condition. And an example of that, if this is a study that looks at, say, markers in the cerebral spinal fluid of kids with leukemia undergoing treatment, it's not exactly a minimal risk study, right? In order to get cerebral spinal fluid, you have to do an LP, and that in itself is not considered minimal risk. However, this may still be allowed in kids because an LP is something that is done routinely on patients with leukemia. They need to do that for both prognosis as well as for treatment. So it's not any different than what they would normally get because they have leukemia. And anything that they may find that help prognosticate in terms of response to treatment or the outcomes of the children with leukemia could be very important and specific to the leukemia. Nevertheless, though, parental consent from one or both parents are needed. And after a certain age, and I can't remember exactly, but something like around 11 or 12, then the child has to at least give assent. They have to say, okay, even if you're actually getting the informed consent from the parents. Now, there are other alternative types of consent. For example, the SALT trial. So this was a recently published trial that compared balanced crystalloid versus saline in patients admitted to the ICU who needed IV fluids for shock. This was a pragmatic, clustered, randomized, multiple crossover trial of adult patients admitted to one of 5 ICU in one hospital. And basically what happened was that an ICU, one of the 5 ICU would be randomized either everybody in that unit getting saline if a doctor ordered saline, okay, or they'll get balanced crystalloids like lactated ringers, for example, okay? And then every odd month or so, they will switch. So if you were getting saline before in that unit, then the next month you may be getting balanced crystalloid instead. And then every few months it will just switch. So this was actually a large study. I can't remember. There has something like 11,000 patients. It was a large number of patients. And for this, they actually got a waiver-informed consent. Now, in order for you to get a waiver-informed consent, okay, that means no consent form was signed. You didn't have to go from either the surrogate or to the patient. In order to get a waiver-informed consent, you must fulfill 4 criteria, of which this study did. 1, that the research involves no more than minimal risk. And that's true because saline or balanced crystalloids, that's something you would give for shock no matter what. And whether you get saline or you get balanced crystalloids is oftentimes dependent upon what the doctor decides, or what they, whichever doctor has a particular penchant for one or the other. As part of this trial, they also gave the option that they will default to saline if you're in the saline group, but if the doctor decided they needed to give a balanced crystalloid for whatever reason, okay, they can override that order. So they're not held to it, but it's just their default nudge ordering, maybe to saline. So because of that, saline and crystalloid is already used clinically. We know what it's given for an indication that doctors meant. They consider this minimal risk. You can only get a waiver-informed consent for research if the waiver itself doesn't affect the patient's rights. And that's true in this case, because normally you wouldn't go to a patient and ask for consent to get saline as opposed to lactated ringers, right? So they're not giving up their ability to consent to something that they normally would require to be consent for, like, say, a surgical procedure. It also, you can only get a waiver-informed consent if it cannot be practically carried out using the traditional consent methods. And because actually the hospital is randomized as a cluster, the entire ICU at a time, and shock is an acute event, you can't say, oh, the patient's hypotensive, let me find family and try to consent, right? It's just not possible. It was considered actually not possible to do the study without a waiver from consent. And then when appropriate, patient will be given information after participation. And that's what they actually put up signs and flyers so that people will know what was being done. Another type of alternative consent in clinical trials for critically ill patients is EFIC, which stands for the exception for informed consent. One example of that is Henry Wang's study, in which they did a clustered crossover randomized control study looking at patients with out-of-hospital cardiac arrest. And what was happening was that an entire EMS service, so like say the entire EMS service that covered metropolitan area of Cincinnati, for example, they'll be randomized to the EMS doing all intubation by endotracheal intubation for all out-of-hospital cardiac arrest. And then actually the next month, they will be told all intubation should be done using a laryngeal mask airway, or LMA, instead of an endotracheal intubation. Now, it is impossible to get informed consent from the patient or the surrogate for out-of-hospital cardiac arrest, as you can imagine, okay? And there's just no time. So a exception for informed consent was granted for this particular study, but the process of getting that EFIC requires actually that they do an information sessions where they will inform the community. So they did it by Facebook, they did it by social media, they also did it by advertisements and posting on the web to let the community know that there's a study that go on, and if they develop cardiac arrest, they may be enrolled into the study. It allows you to actually take input from the community, but doesn't necessarily mean you have to change or respond to all of their concerns, because some of it may not be scientifically valid. So with regards to the question that I had asked before, which of the following is true about the informed consent in clinical trials of critically ill patients? It is actually all of the above. Okay. So quickly, a little bit on the FDA-regulated clinical trials. So FDA reviews drugs, devices, and biologics to give approval for safe and effective use of the products. But as many of you guys know, oftentimes these products can be used as off-label. So you use it for other things other than what is actually in its brochure as FDA-approved uses. So if you're actually doing a study using a drug, okay, you don't necessarily need the FDA to give you something called an IND, investigational new drug application, which can be a bit of a long process. You don't need to do that if you're not going to be using the results of the study to support a new indication, a new labeling, a new change in advertising for the drug, right? So if you kind of say, is this effective as an off-label use, but I have no intention of asking the FDA to change the indication for the drug, you may not necessarily need to put in an IND. If the research actually doesn't involve a route or dose that increases the risk, like for example, giving a drug that's normally oral, but you want to give it IV instead, okay, then you may not require an IND. And of course, your study still needs to be IRB approved with an approved informed consent. Devices are similar. Devices is actually defined as any kind of health product that does not act by a chemical reaction or by being metabolized. And instead of an IND, you have to get something called an investigational device exemption. And then how you get it depends on whether it's considered a significant risk device or a non-significant risk device. So a significant risk device is anything that's intended for implantation, life support, or is used to diagnosis, curing of a disease, mitigating or treating the disease, or preventing serious risks to the subject's health, safety, or welfare, okay? But a lot of devices we use in healthcare are considered non-significant risk device, okay, because they're none of those things. So an example of that might be actually, a device that you attach to the patient to make sure that when they're ventilated in the ICU, the head of the bed is always elevated at 30 degrees, okay, to prevent ventilator-associated pneumonia. The device doesn't get inside the patient. It is more of an adjunct to help nursing, make sure that the patient is at the right angle. So as such, would be considered a non-significant risk device because it's not implanted. It's not really there to diagnose or treat or relieve the symptoms. It's there to help the nurses deliver the kind of care that they're supposed to do. But the same rules for informed consent or waiver informed consent or emergency use or EFIC still applies. Next, I want to talk a little bit about data and safety monitoring boards, because these are actually an important ethical safeguard that has been put in for critical for research that almost all research that involves critically ill patients. The data safety and monitoring board is often charged with which of the following tasks: design of the trial, developing the statistical analytical plan for the trial termination if the risk and rationale for the trial changes, analysis of the trial results, or writing the manuscript for publication. Okay, good. So let's continue that and see. So why do we have data safety monitoring boards? Because actually they're now required by many agencies, including the FDA, the European Medicine Agency, the NIH, and basically any clinical trials with possible major morbidities required to have a DSMB. And the NCI, the National Cancer Institute, just requires it for every study whatsoever. Okay. The DSMB is a committee that has a median of about 4 members, but it can range from 1 to a nightmare of about 20. And that's a very large committee. And any committee that has 20 people, as you can imagine, is unwieldy. It almost always consists of at least one statistician. It may have an ethics person, and then the rest are usually content experts. But you may have special members on your DSMB depending on the trial. It could be a layperson or like a prisoner, for example. And all is supposed to be independent from the trial, the investigator, sponsor, and funding agency. So for example, they cannot even be somebody on the DSMB who is from the same institution as one of the investigators. The investigators of a trial has to do certain reports to the DSMB. They have to give them the trial protocol for them to review. It has to share with the DSMB the data confidentiality plan, as well as the safety monitoring and adverse event reporting plan. It also has to give to the DSMB an interim analysis plan. Is there an ability to stop the trial early for fertility? Maybe yes, maybe not. That's a design from the investigators. There usually almost always is a plan to early termination if there's signs of harm, okay, from adverse events or from outcomes. And then in some trials, but not in others, there might be a plan to stop early for benefit. Okay. There's also reports to the DSMB that might involve blinded or even unblinded data on adverse events and study outcomes, because they're the only people during the course of a trial who may be able to see the unblinded data to see if, let's say, one arm of the trial has more adverse events than another. So before the trial begins, the DSMB is supposed to review these documents, and they can give recommendations back to the investigators. And the investigators could, agree and make changes to the protocol, or they could say no and push back to the DSMB. And there's a bit of a back and forth until all the members are in alignment. During the trials, they will have scheduled review of the safety data, and it could be unblinded in most cases, so that they can see that, there's not a large amount of adverse events in one particular arm or another. There will also be predetermined interim analysis. So rather than say, okay, we're going to have every yearly meeting or every 6 months meeting, we're also going to have an additional meeting when we have reached 500 patients, for example. That's predetermined, and at that interim analysis, they're supposed to decide on whether or not they want to continue the trial or not, and that's a decision by the DSMB. In addition to these meetings, they may also have an ad hoc meetings if there is a serious adverse event, and they'll review the event and decide if you need to change the trial protocol, the study procedure, or actually inclusion exclusion strategy, or stop the study, okay, because of the adverse event. And at each point, they decide on continuation, modification, or termination of the trial. But in essence, actually, the DSMB has the power to stop the trial for any reason they want. I have actually participated in a clinical trial where there was no interim analysis for stopping due to futility. Okay. Nevertheless, actually, the DSMB decided to stop the trial early for fertility, even though that was actually not part of the initial investigator's plan. So regards to that question, the Data Safety Monitoring Board is often charged with which of the following tasks? It is what the majority of you has decided. Trial termination if the risk and rationale of the trial changes. So lastly, in the last 5 minutes or so, I want to talk about the quality improvement. So this is a question I'm often asked. Is it research or is it quality improvement? This is getting to be an increasingly difficult question to answer. In general, if the project is for internal use only and your purpose is just to collect the data to see if something that you're implementing for clinical reason is working or not, and you're only going to share the data with other people who work in that same institution or in that same unit and they're all involved in the clinical care, then it is not considered research. You do not need an IRB approval, even if you are collecting data. And even if you're collecting, identifiers, you're allowed to do that. However, if you have any desire to present the results of that project in any forum, you're going to submit it as an abstract, you're going to present it at a national meeting, you want to write it up for an application, for a publication, then you need to have an IRB approval before you can do any of that. Now, this is becoming more challenging because some of you may have heard about learning healthcare systems. And increasingly, more and more institutions are moving towards a learning healthcare system. And what that basically is rather than you and I doing a quality improvement projects and then seeing if it works, and then yay, it works, or yay, it doesn't work, and then move on, they're trying to actually integrate a systematic examination and reevaluation, as well as analysis of data of any kind of clinical initiative, any kind of quality improvement projects in the hospital, so that you systematically try to approach the project, you measure the outcome, you take what you understand from the outcome, and you feed it back into the system so they learn to do this better the next time. Oftentimes, actually, research is integrated into this, right? How do you systematically collect data? How do you systematically analyze the data? And how do you report the data? So now, actually, it is now more and more common that you'll see quality improvement project being elevated to much more rigorous research standards. However, a lot of IRBs hasn't yet figured out what that means with regards to IRB approval in a learning healthcare system. But it is true, however, that you can't just think a quality improvement project doesn't actually need IRB approval. And in fact, actually, as I mentioned in the very beginning, many quality improvement projects can actually be considered a clinical trial, especially if you're planning to do this prospectively and you're planning to collect outcomes to see if that initiative improve patient mortality or outcome or decrease adverse event. And in that case, you're going to need an IRB approval. And to do that, you're going to need to make it clear to the IRB what exactly is done as part of the quality improvement project and what is done as part of research. So I'll give you an example. One of my mentees is helping to implement a clinical project to implement a peer support group for families of patients in the ICU. So that's going to be done as part of actually a clinical initiative, where they can be running groups where families of patients in the ICU can talk with each other. But as part of that, he's going to want to actually conduct some surveys to look to see actually whether the families have found this peer support group to be helpful. Did it help them in terms of actually communicating with the ICU? So in this case, the clinical project, a quality improvement project, is the implementation of the peer support group. And what we're saying is the research is these instruments that we would deliver to measure actually the family's response to that peer support group. Did they find it useful? Did it help with communications? And we have to make that very clear to the IRB about what is done clinically and what is done as research. And quality improvement doesn't mean that there's no risk. There's always risk. Anytime you collect data, there's risk to data security and privacy. And then risk from intervention still exists, because if you didn't do a good job of implementing a quality improvement project, it can actually lead to more harm. An example of that is prone positioning in ARDS. This is a quality improvement project. We should teach our teams how to actually prone a patient when they have severe ARDS. But if we actually did a poor job of doing that, we could actually have more adverse events of, say, accidental extubation or accidental loss of lines. And as I mentioned before, unfortunately, most IRBs are not familiar or experienced with this intersection between quality improvement research and learning healthcare systems. So if you're going to be doing some of this, expect that actually you should have an ongoing dialogue with your IRB and to start this process earlier rather than later. And with that, actually, I want to thank you all for your attention, and I'm happy to entertain questions.
Thank you so much for the great presentation. I think for anyone that's either interested in research or actively doing research, you hit on so many good points and great pearls for us to be aware of. It's obviously never an easy task to, put together a clinical trial, let alone a multi-center trial. So it's nice that you're able to share your expertise with us. One question regarding the requirements for waiver of informed consent, as you gave in the SMART trial example, is that a national standard like those 4 questions, or is it IRB dependent? Or
Yeah, that's a great question. It is a national standard. Those are the requirements set off by the common rule. So each local IRBs may have a different form for you to fill out to indicate that you have meet those 4 criteria. But whatever form they use, they actually have to make sure that you hit all 4 of those in one way, shape, or form.
got it, that makes sense. And then I want to touch upon the SMART IRB, something that I hadn't heard of before, but definitely sounds like a very, very useful resource when it comes to multi-center trials. Are there any barriers that you've kind of come across or experienced for centers to not join SMART IRB?
No, that's a great question also. I don't know. I think first of all, if you're in a center that's affiliated with a CTSA, they probably have already either investigated it, known about it, or already joined the SMART IRB, because this is something that was kind of put forth by the NIH as well as the CTSA sites. But if you're actually a part of a community hospital and the community hospital has their own local IRB, they may be less interested in joining the SMART IRB, because some of those local IRBs are a little suspicious of losing autonomy. Like they just don't want to give up power or control over what happens in their institution. In addition, some of you guys may have participated in industry studies that uses a commercial IRB. So you may have heard of them. Western IRB is one, for example. I don't know that those IRBs are all that keen on utilizing the SMART IRBs, because it is to some degree actually a competition to them, right? They want to actually serve a centralized IRB in general, but the SMART IRB basically creates central IRB with academic medical centers for NIH sites. So those may be some reasons.
I see. Thanks for explaining that. Looks like we have a few questions on board here, so let me read the first one. Our unit recently implemented standardized rounding rules that fostered multidisciplinary attendance on rounds. We measure attendance before our intervention and after, and found that we had better attendance. We didn't get IRB approval. Can we publish that?
You cannot publish that unless you get the IRB approval. Okay, it's fine for you to have collected all that data. It is fine for you to have done that and actually to show it internally. But once you go and want to put it into a public arena, then you need to actually get IRB approval. Now, understand, for what you described, it doesn't sound like you need an IRB approval per se. It may actually qualify as what they call an exemption from an IRB approval process, because all you really did was measure attendance, right? There's no patient data that you collected and so forth. So you may be able to have a simple thing of just submitting it to the IRB and they send you a letter. It's like, oh yeah, this is exempt from review. You don't need to do anything else. That's enough. That's all you need to say, okay, I already submitted, they say it's exempt, and now you can publish.
Great. We have another question. Can you explain the difference between IRB approval and waiver with quality improvement?
Yeah. So they're different. IRB approval means that you have gotten your institution to review your study and approved and allow it to be done. Okay. How you do it is what the waiver informed consent is, right? So one aspect of saying you're approved to do the study is how are you approved to do the study? How are you getting a consent, for example? So depending on whether or not your study qualifies that meets those criteria for waiver informed consent for a quality improvement, for example, then the IRB approval might come and say you're approved for the study and you are approved for waiver of consent. Or if it doesn't actually fulfill those criteria, they'll say we will approve the study, but only if you get informed consent from each of the participants. Does that make sense?
I think to answer the question. And then we have one more, which is, it looks like a little bit of a comment, but a good point to maybe highlight how certain states may have their own specific laws. So this listener points out, I believe that New Jersey is a state that uses consensus if family members are involved in MPOA disagreements. The case law used for the disagreements is the one used for research consent in vulnerable populations.
Yes, that is very common. So many states actually doesn't necessarily have a law per se, but it's case law, which is basically decisions that have come down from some kind of a court dispute, and they basically extend that to research as well.
Awesome. That's great. I mean, it's really, empowering to know that even as the investigator researcher, you really have to know your stuff and look into it, and sometimes bring that information over to the IRB, as you kind of mentioned. So many things go into it.
Yes, and I think that's one of the things that I hope many of the listeners will be able to carry forth from this, is that don't think of the IRB necessarily as like the adversary, the one that like, oh, they torched my study because they wouldn't give approval, or they were impossible. Understand that the IRB themselves sometimes are not particularly familiar with your type of research. Like, for example, if you're dealing with critically ill patients, they don't necessarily are the experts in doing that if you're the first in your institution or you're one of the few to be doing it in those instances. So to some degree, actually, if you really feel committed to these kind of research, you should educate the IRB. And for the most part, actually, if you take the time to be cordial and professional and educate them on these special issues, they are also then more responsive. They might actually invite you to serve on an IRB to provide content, which is entirely up to you whether you want to do that extra job or not. But do understand that it is to some degree a two-way street, and there's a responsibility for us as researchers to also educate our IRBs with regards to special issues with these patients.
That's great. Thank you, Dr. Gong.
You're
Thank you
welcome.
to our presenter and the audience for attending. So again, you will receive a follow-up email with a link to complete an evaluation. The link to that evaluation is also listed in the chat box for your convenience at the bottom of this page if you do not wish to wait for the follow-up email. You only need to complete it once. There is no CME associated with this educational program. However, your opinions and feedback are important to us as we plan and develop future educational offerings. Please take 5 to 10 minutes to complete the evaluation. And again, the recording for this webcast will be available on the SCCM YouTube channel within 5 business days. That concludes our presentation today. Thank you all for joining us, and thank you again, Dr. Gong.
Thank you for inviting me.